Before 2013, clinicians evaluating highly volatile, irritable children faced a significant diagnostic gap. The lack of a specific category created clinical uncertainty. This uncertainty led to a documented surge in pediatric bipolar disorder diagnoses, as clinicians struggled to categorize children who did not fit the traditional manic-depressive cycle. For the children involved, this misclassification meant being placed on intensive pharmacological paths involving heavy mood stabilizers and antipsychotics, treatments designed for a condition they did not actually have. To address this, the DSM-5 introduced a structural correction in 2013, Disruptive Mood Dysregulation Disorder, or DMDD. This provided a specific home for chronic irritability, intentionally separating it from the bipolar spectrum, creating a precise clinical pathway for mismanaged patients. Understanding this disorder requires first establishing the highly specific clinical profile that defines a DMDD presentation. We must then navigate a strict hierarchy of differential diagnoses to isolate DMDD from other childhood conditions with overlapping symptoms. Finally, we will examine the school-based frameworks required to deploy these treatments effectively within K-12 environments. A school-based intervention protocol relies on the accuracy of this diagnostic entry point. A DMDD diagnosis is built on a dual clinical requirement: the presence of acute outbursts layered over a constant, irritable baseline. This graph tracks a year of dysregulation. Severe, disproportionate temper outbursts spike at least 3 times weekly. Between outbursts, the child maintains a chronic, irritable baseline most of the day. This pattern must persist continuously for 12 months, across at least 2 distinct settings. To differentiate DMDD from other developmental shifts, the onset of these symptoms must occur before the age of 10. The diagnosis is specifically reserved for children and adolescents between the ages of 6 and 18. While irritability is common in childhood, these strict thresholds mean DMDD applies to only about 2 to 5% of children in the U.S. This creates a profile of a child in a constant state of dysregulation, altering their long-term development if the baseline is not addressed. Because chronic irritability is a feature of many disorders, the DSM-5 requires clinicians to follow a rigid diagnostic hierarchy. Clinicians must first rule out anxiety disorders, trauma, and autism as the primary drivers of the behavior. Separating DMDD from episodic pediatric bipolar disorder is critical, as chronic DMDD requires regulation-based therapy, not heavy mood stabilizers. If symptoms overlap with oppositional defiant disorder, DSM-5 mandates diagnosing DMDD instead. However, ADHD is a common co-occurring condition that exists alongside DMDD. Research into these co-occurring cases has revealed an important clinical insight regarding treatment. Treating the ADHD component with stimulants often results in a measurable reduction in the frequency and intensity of the separate DMDD outbursts. Maintaining this rigid diagnostic hierarchy ensures that patients receive the correct medication and behavioral protocols from the start. Effective treatment moves the clinical insights of the DSM-5 into the environment where the child spends most of their day, the school system. Comprehensive management relies on 3 pillars: parent management training, CBT for emotional regulation, and structured school-based behavior plans. The MentalSpace school framework bridges these pillars in Georgia's K-12 districts, delivering multimodal campus care. It provides dedicated therapist teams and same-day teletherapy for immediate clinical support. The framework also extends to staff wellness, crisis intervention, and violence prevention programs. Deploying school psychiatric infrastructure demands complex compliance. MentalSpace helps Georgia districts meet upcoming HB 268 deadlines while maintaining strict HIPAA and FERPA adherence for privacy. The model integrates financial accessibility, offering $0 Medicaid billing and accepting major commercial plans like BCBS, Cigna, Aetna, and Peach State. Clinical advances in the DSM-5 only reach the student when school systems have a legal and financial mechanism to deploy them. When districts integrate these support structures, the outcome data shows a measurable impact across clinical and operational metrics. An 89% improvement in attendance demonstrates that addressing DMDD directly reduces the chronic absenteeism often associated with behavioral dysregulation. A 92% reduction in reported anxiety highlights the efficacy of the integrated CBT and regulation interventions. Furthermore, an 85% family satisfaction rate indicates that the support system successfully extends from the classroom back into the home. The 2013 diagnostic shift provided the necessary clinical framework to identify and treat the specific symptoms of chronic pediatric irritability. Achieving stability for these children requires connecting that clinical accuracy to the school environment where they spend the majority of their time. This work is carried out by licensed, culturally competent, and diverse therapists who understand the specific needs of Georgia's student populations. Successful pediatric mental health care is the result of matching precise clinical diagnosis with legally compliant, accessible integration. To learn more, visit